My name's Sandeep, and welcome to the next session, which is going to be on how to review a patient who's short of breath. With a doctor on call, and you've received a bleep to review a patient who's short of breath. What are the questions that you should ask the referring nurse? Well, the first question that you should ask is, when did the patient become short of breath? Next, what are their oxygen saturations? What is their respiratory rate? What is their heart rate? Does the patient have any known underlying lung conditions, for example, COPD or asthma? Is the patient complaining of any other symptoms? Do they have any chest pain, or do they perhaps have a cough? Next, you want to ask the nursing staff to complete a set of observations, including the saturations and the temperature. You should ask the nursing staff to immediately put the patient on some oxygen, particularly if their saturations are low, aiming their oxygen levels to be above or equal to 94%, or if they're diagnosed with COPD, then between 88 and 92%. So let's start off with an A to E assessment. How would you assess a patient who's short of breath? First, we have A, airway. What you want to do is look for evidence of angioedema. So is there any tongue swelling or lip swelling, as you can see in this picture? This would mean the patient might have underlying anaphylaxis, secondary to a recent drug infusion, perhaps. Is the patient able to maintain their own airway? If it's not tongue swelling, perhaps there's a foreign body that's stuck. This is something to note in patients that are elderly or perhaps confused. Moving on to breathing, there's many signs that you can pick up while a patient's short of breath. One of them can be crackles. Patients can present with either unilateral or bilateral crackles. Unilateral crackles are more in keeping with infection, such as pneumonia. Bilateral crackles, particularly at the bases, would be in keeping with heart failure, for example, because of pleural effusions. Next, we have wheeze. Patient can have a wheeze for many reasons. Again, a cardiac wheeze might be present with heart failure, or a patient might have a wheeze because they have underlying asthma or COPD. You might notice that the patient has unilateral reduced air entry. Again, this is something that might be present if a patient has a pleural effusion or a pneumothorax. Tachypnea may be present. A silent chest is a worrying sign in asthmatics. Patients often need immediate management, and they might end up going to ITU. When checking the chest expansion, you might see seesawing. Again, it's quite a worrying sign, particularly in asthmatics, because it can indicate that the patient's becoming quite tired. There might be dull percussion, seen in pleural effusion, or hyperresonant percussion, seen sometimes in pneumothorax. And look at the patient from the end of the bed. Do they sound chesty? A chesty patient, particularly an elderly one, might have an aspiration. Okay, moving on to C, circulation. Patient might have evidence of a raised JVP. Now, this can be present in a patient who's got heart failure, but also a patient who perhaps has underlying pulmonary embolism. Next, there might be signs of shock. These can include dry mucous membranes, cold peripheries, cap refill more than 2, hypotension, or perhaps tachycardia. Patient might also have reduced urine output as part of that. When you're listening to the chest, listen out for murmurs. A patient who's known to have a valvulopathy like aortic stenosis might be becoming short of breath because the aortic stenosis is worse, or it's now progressed to heart failure. Or the patient might have developed a new murmur, for example, mitral regurg after a recent myocardial infarction. Look for evidence of peripheral edema. Pedal and sacral edema can occur in heart failure. Although not strictly part of circulation, you might notice that the patient has pulsatile hepatomegaly. Again, if this is present with a murmur, this might be indicative of tricuspid regurgitation or signs generally of right heart failure. Look for cyanosis, so both central and peripheral. This will give you an idea about the level of hypoxia the patient's undergoing. And if you notice a right ventricular heave or even a pleural rub, this might be in keeping with PE. Moving on to disability. Check the patient's alertness. So generally doing an ABPU, but also checking their GCS. In patients with COPD, reduced GCS can be because of CO2 retention. Can the patient complete full sentences? This is one of the tools we use to identify the severity of asthma. So particularly if asthmatics can't complete full sentences, it's more worrying than if they could. Exposure and everything else. Expose the chest wall and make sure that you're looking for evidence of trauma, of drains, check the previous scars from surgery. Then look for lymphadenopathy. If it's present, particularly within the neck or in the axilla, you might worry about primary or hematological malignancies. Is there any evidence of crepitus on the chest? This might be because of recent trauma and surgical emphysema that's present. A good example of surgical emphysema can be seen on this chest X-ray, where you can almost see the muscle fibers of the pectoralis muscle on the right. Check for a CO2 retention tremor. Again, an important marker of deterioration within COPD patients, and it might change your management plan. Look for evidence of clubbing. Here we have a nice example of clubbing. At the top here, you can see Shamroth's window between both the nails, and then here it's disappeared. Does the patient have evidence of a rash? Particularly if they have angioedema and they have an urticarial type rash, like a wheal, you would be more concerned about them having had some sort of anaphylactic reaction. And lastly, look for calf swelling. If you're thinking about PE, you might want to look for more of a distal clot that might have broken off. So there's lots of things you want to ask within the history. The first sort of question that you need to find out is this shortness of breath new? So before this, what was their previous exercise tolerance? How much could they manage, perhaps on flat ground, where they're managing 100 meters? What is the exercise tolerance now? Has it dropped to 50 meters or so? If it's new, then you need to ask about how it came on. Did it come on suddenly, or has this been a slow, progressive shortness of breath? Perhaps they noticed it when they were lying flat. Does the patient have any other symptoms? Starting off with a cough. Do they have a new cough? If they do, is it productive or is it dry? If it's productive, then what colour is the sputum? How much sputum are they making? If it's not a new cough, then how has it changed? Perhaps the colour or the quantity of sputum has changed from previous. It may have been clear, now it's coloured. Does the cough only occur at certain times of the day? For example, is the cough only there at night time? Is there any evidence of hemoptysis? Is there any blood within this sputum? Does the patient have any chest pain? Patients might complain of pleuritic chest pain when they take a deep breath or when they cough. They may also complain of having recent chest pain that was central and preceded the shortness of breath. Perhaps they've had a recent myocardial infarction. Ask about other associated symptoms. Palpitations. Do they notice any problems with their valves? Are they taking a lot of nebulized salbutamol? Perhaps they've been feeling dizzy or faint. Patients can present with collapse in pulmonary embolism, but also hypotension can make them feel like this in both community-acquired pneumonia and also heart failure. Has a patient complained of any tiredness or weight loss? Perhaps there's an underlying diagnosis of TB or a mass, particularly if there's weight loss. But one of the differentials to consider is anemia. And lastly, is there any fever? Again, an array of infections that can cause that. Has the patient had any injury? One of the things you're worried about is pneumothorax. And then have they travelled anywhere recently? Aside from COVID, there may be different viral infections that you'll be concerned about, or bacterial infections for that matter, MERS, SARS, TB, depending on where they've travelled. Try and work out what the aggravating factors are. So are there any allergens or irritants, for example, dust mites, paint, pet dander, that might be causing their shortness of breath to be worse? Have they noticed that lying flat makes it worse? Or perhaps their shortness of breath comes on at night time or with cold weather, again keeping them in line with either heart failure or asthma. You want to establish from their past medical history whether they have any lung conditions, whether they have any heart conditions, particularly heart failure, or any condition that could lead to heart failure. Have they previously been diagnosed with TB or previously been diagnosed with cancer? All of this would put them at greater risk of having pulmonary embolisms, for example, if they've been to theatre recently, or they've had a recent fracture or admission to hospital. That, along with obesity and thrombophilia, would also put them at risk of developing a clot. Go through their drug history. Are they on inhalers, perhaps for asthma? Are they on home nebulizers or home oxygen for COPD? That will give you an indication of how poorly controlled their COPD is. Perhaps they're on morphine for shortness of breath at home, or morphine's causing new respiratory depression. Have they been recently started on a course of NSAIDs or beta blockers? This could make breathing worse in asthma. And finally, cover their social history. So ask them about their job. Had they previously been exposed to asbestos? Perhaps they've got asbestos-related interstitial lung disease. Are they a health worker? This would be putting them at risk of other conditions such as TB. Make sure you take a thorough smoking history and ask about any pets, particularly birds. Are they cleaning out bird cages regularly? Have they noticed the shortness of breath has come on slowly? So we're thinking of things like various types of pulmonary fibrosis, and obviously work out their exercise tolerance. Moving on to investigations. So the first thing that we usually do for our patients is to do assessment blood tests. We want to check for FVC and CRP. These will look at markers of infection. You might want to do a mast cell tryptase if you think there's any evidence of the patient having anaphylaxis. Checking LFTs and USNEs is important because both can cause edema leading to shortness of breath. And then clotting, D-dimer in particular, might be of use in a patient who you think might be having a PE. Now, BMP can be useful, although not in the acute setting, for patients who you think might be suffering from heart failure. It might be appropriate if the patient's desaturating to check for an arterial blood gas. So the ABG might show many things. So if a patient's septic, it might show a raised lactate. It might show respiratory alkalosis, so a low CO2 in a patient who's presenting with a pulmonary embolism, or even hyperventilation if the oxygen's normal. It might show you either compensated acidosis or acute acidosis in a patient who has COPD and has high CO2 levels. One other worrying thing that you might want to consider is a normal CO2 level in a patient who's asthmatic, because this can be a sign that they're tiring. Next, make sure you get an ECG. ECGs can show a variation of things that can cause shortness of breath, arrhythmias, stemming. It might be appropriate at this point to get a chest X-ray, particularly if there are any signs on examination. So chest X-rays can show consolidation, collapse. They might show pulmonary edema if there's any heart failure. Highly lymphadenopathy, as is present on this chest X-ray, might be maybe there if there's some evidence of sarcoidosis, for example, or even if there's some sort of evidence of malignancy. You might see fibrosis, so lower zone fibrosis if they've had asbestos exposure. You might see some evidence of pneumothorax, hyperexpansion if they've got COPD, and if there's bilateral infiltrates, this might indicate that the patient's got acute respiratory distress syndrome. It could be appropriate to get an echo in the patient, and an echo might show a variety of things as well. So left ventricular hypertrophy, left ventricular systolic dysfunction. There may be evidence of HOCM. There might be right ventricular hypertrophy, or if the patient's had a recent PE, it might be appropriate to get an echo to check for right heart strain. If there are any murmurs or auscultation, it will be important to look at the valves to look for valvulopathy. If we think that the patient's chest might have some sort of mass or a clot, it's important to get a CT, so either a CTPA or a CT chest. These may show effusions, again, consolidations. Patients might be confirmed as having an emboli or a thymoma, SVC obstruction. In patients with asthma, it's important to monitor the peak flow. So acute asthma, the peak flow will have deteriorated, but it's important to work out what their normal is and compare it to their baseline. You can use the peak flow to check the treatment response, and in a non-acute setting to check the diurnal variation if you're not sure about the diagnosis. And of course, if you're thinking the patient has some sort of infection, send the sputum both for MCNS and for TB. I'm going to briefly talk about anaphylaxis. So urticaria can be the first sign of anaphylaxis. If you think your patient has anaphylaxis, then the immediate treatment would be to put them on 15 litres of hypooxygen, establish the cause. So perhaps they've been recently started on penicillin, stop the causative agent, especially if it's running through an IV line. Patient needs adrenaline, IM 500 micrograms, and some IV fluids to keep their blood pressure up. At this point, it's important to use crystalloids rather than colloids because patients can develop allergies to colloids. Salbutamol nebulizers may be appropriate at this point, but IV steroids and IV antihistamines are the mainstay. And particularly if you think the patient's reaction is mild, you might start off with IV steroids and IV antihistamines. Investigations for anaphylaxis would include doing a mast cell tryptase at 0 hours and then repeating this at between 6 and 24 hours. One of the other conditions that can cause patients to have shortness of breath is COPD, and we've mentioned it quite a bit. I'm just going to go through the immediate management for COPD on a ward setting. So you might want to get a chest X-ray. You may see some hyperexpansion in the chest X-ray, but there may also be evidence of additional infection on the consolidation or collapse. It's important to treat exacerbations with steroids plus or minus antibiotics. So usually we use 5 days of prednisolone. If there's any evidence of infection, for example, they have symptoms of pneumonia, productive cough, change in their sputum, or temperature, then antibiotics might be appropriate. Patients can develop both lower respiratory tract infections and pneumonia. So lower respiratory tract infections can be caused by H. influenzae or Moraxella in COPD patients, and pneumonias usually S. pneumoniae. 30% of infective exacerbations of COPD are actually viral, so it's important to look for signs of bacterial pneumonia. So the treatment essentially is to give steroids, give antibiotics if appropriate, and give nebulizers. You would do an ABG at the onset to make sure that the CO2 and the pH are within normal limits. At this point, you would give them an hour of medical management and then recheck the ABG. Chest physio might be appropriate for some patients, especially as in a non-acute sort of way in the next couple of days while they're having their steroids, you might benefit from some chest physiotherapy. In terms of nebulizers, you'd use both salbutamol and ipratropium nebulizers. So briefly talking about NIV, if after an hour of medical management, your ABG shows that the pH is between 7.25 and 7.35, or perhaps it's not improved, the CO2 is not coming down, the patient might be an appropriate candidate for NIV, which is essentially BiPAP or non-invasive ventilation. If the pH is less than 7.25, then you really ought to contact ITU if it's appropriate, because a patient at that point needs intubating if they've had an hour of treatment. Settings for NIV, so in terms of the EPAP pressures, this would be EPAP or PEEP, be 5 centimeters. The reason it's quite low is to avoid pneumothorax. IPAP, usually start that on about 10 centimeters. That can be increased up to 20. And your backup rate is usually 15, a respiratory rate of about 15. There are some contraindications to using NIV. So for example, if a patient's got a lot of secretions or they've got a low GCS and they can't protect their airways, then they wouldn't be a candidate for NIV. Similarly, if they had recent upper GI surgery or bowel obstruction, if they had upper airway obstruction or they were actively vomiting, they wouldn't be a candidate for NIV because it's contraindicated. Sometimes patients can get quite agitated on NIV, and in these patients it might be worth giving a little dose of morphine. So for example, 2.5 to 5 milligrams of morphine IV, and if that's not helping, you can always add a benzodiazepine. For patients that are on NIV and requiring nebulizers, at that point you need to remove the mask to give the nebulizer and then put the NIV back on once they've had the nebulizer. Next, we've got asthma. So asthma has various categories. It's important to categorize the asthma exacerbation correctly. So we've got moderate, severe, and life-threatening, which we're going to focus on. It's important to monitor the peak flow rate because this will give you an idea of how bad the asthma is. So if the peak flow rate is between 33 and 50% of normal, as you can see, you can work out what normal is for a patient based on their age and their height and their gender. If it's up to 50%, then it could be classed as severe. If less than a third of the normal, then this would be life-threatening. And again, we spoke earlier about not being able to complete sentences and having a silent chest. It's important to admit patients who either have life-threatening or severe asthma. It's important to admit patients also who didn't respond to initial treatment regardless of their categorization. So in terms of the acute treatment for asthma, it's important to consider a chest x-ray. If they have life-threatening asthma, if you think the patient might have had a pneumothorax, particularly secondary to the asthma, or if they're not responding to treatment, get a chest x-ray in the patient. Most asthmatics are quite young, so they're not really keen on coming to hospital if we keep doing ABGs. So the advice is that we do an ABG if the patient's saturations drop to less than 92% on air. Acutely managing their asthma involves giving them some either oral prednisolone or IV hydrocortisone for 5 days. Salbutamol nebulizers and ipratropium nebulizers. So salbutamol, 2.5 milligrams, can be repeated every 10 to 15 minutes and reassess the peak flow and the SATs at that frequency. One of the things you have to be aware of is that salbutamol can also cause tachycardia and lactic acidosis. So if you're monitoring any blood gases and they're acidotic, that's something that you need to just keep in mind. If the patient's not responding to the nebulizers and the steroids, sometimes we give patients IV magnesium. So we'd give them 2 grams, 8 millimoles of magnesium IV over 20 minutes. The next step in the treatment plan would be to try IV aminophylline if this doesn't work. So IV aminophylline, if the patient's not already on oral maintenance, the offering at home would be a 5 milligram per kilo dose IV over about 20 minutes. If none of the above has helped, then the patient really needs to be transferred to ITU. So either intubation if the patient has any sort of, if the patient has treatment failure from the above sort of options, or if they have normal or high PCO2. So if the patient's acidotic, or even if they have normal CO2 on the gas, then they need to go straight to ITU. One or two things that you probably ought to be aware of in terms of aminophylline, because it's not very commonly prescribed or administered. Aminophylin's a phosphodiesterase inhibitor, so it's an adenosine receptor antagonist. It can cause patients to have tachyarrhythmias, so they need to be on a cardiac monitor. We spoke about the loading dose. If the patient's already on theophylline or a maintenance dose, then they need to be on a bit of a higher dose. So instead of 5 milligrams per kilo, it needs to be 500 to 700 micrograms per kilo per hour. If they're elderly, it's about 300 micrograms per kilo per hour. It's important to monitor the theophylline levels because sometimes the theophylline levels can be reduced by P450 inhibitors, inducers, and they may be co-prescribed. Next, we've got PE. So PE is another common cause for patients to be short of breath while in hospital. So one of the common investigations we may do is a D-dimer. D-dimers, the range varies from hospital to hospital, so check your local guidance. They're important in lots of circumstances, but some circumstances they're not very good to use are in cases where there might be other causes of inflammation, for example, a patient who has cancer, a patient who's pregnant, or a patient who's got concurrent infection. Other things you may use to help you gain confirmation or to refute whether a patient might be diagnosed with a PE would be like a PERC rule or a Wells score. So the Wells score looks at whether the patient may have evidence of underlying DVT, of their heart rate being raised. They might look at recent risk factors, for example, immobilization, surgery, cancer. And the PERC rule is to rule out PE. So if there's no criteria present, so the criteria involved like the heart rate being more than 100, age being more than 50, and SATs being less than 95%, any cancer being present. If none of the criteria are present and the pretest, then the pretest probability is about 15%. So next we've got ABGs. So in a patient who's got PE, ABG might show a low CO2 level, plus or minus a low oxygen level if there's a very large PE. ECGs can show a raised heart rate, so sinus tachycardia. They might show right bundle branch block or T-wave inversion in V1 to V4. One of the things that you might learn for your exams is S1, Q3, T3. So here we've got S1, Q3, and T3. Chest X-rays often show absolutely nothing, so they're usually normal in patients with PE. A CTPA is usually first line for patients that have suspected PE, and sometimes a VQ scan is used in those patients who have renal failure, can't have a CTPA. If it's suspected there's a large clot, then an echo may be requested to check for right heart strain if it's not already visible on the CT. If there's right heart strain present, it might guide the clinician to consider thrombolysis, and that would obviously involve senior support. Treatment for PE would acutely involve sitting the patient up unless they've got low blood pressure, making sure they have 15 litres of oxygen, arranging the CTPA, plus or minus echo, and thrombolysis if appropriate. So for example, if it's a massive PE and they drop their blood pressure, then you would want to get a senior opinion to get to consider thrombolysis. One of the things you might do if it's not a large PE is to anticoagulate the patient. So there's different anticoagulants that you might use, often in an acute setting when the patient's first being worked up. They might have low molecular heparin, so enoxaparin, 1.5 milligrams per kilo over 24 hours subcut, or perhaps dalteparin, depending on their weight. Patients used to be put on low molecular weight heparin, particularly if they had underlying cancer, and they used to be put on warfarin. However, the preference these days is to start them on a DOAC, so something like apixaban or rivaroxaban. If the patient has a high bleeding risk or a very low a very low EGFR, then IV heparin is sometimes considered. Patient's been diagnosed, eventually a decision needs to be made about how long to continue the anticoagulation for, so whether or not this P was provoked, and also whether, if it was unprovoked, whether it would be appropriate to run a thrombophilic screen or perhaps a malignancy screen. So moving on to pneumonia. There's two types of pneumonia that patients are usually diagnosed with. This is community-acquired or hospital-acquired pneumonia. So hospital-acquired is defined as more than 48 hours after admission and not felt to have been incubating the infection at the time of admission. Patients can have gram-negative bacilli with hospital-acquired pneumonias, so Pseudomonas, Klebsiella E. coli, but also might just present with strep pneumoniae or Staph aureus. Patients may also develop what we call aspiration pneumonia. This is essentially like a sterile pneumonitis, aspirating the gastric contents down the trachea. Risk factors can include having a low GCS, for example, if the patient's septic or they're post-operative and some of the anaesthetic is still wearing off. Patients might have esophageal problems like cancers or neurological issues like dementia or MS, problems swallowing with Parkinson's. We may have created problems by booking the patient for interventions like NG tubes, or the patient might have had a recent bronchoscopy or an OGD, which has put them at risk. If you do think your patient is at risk of having a poor swallow, then it's important to get a swallow assessment done by a speech and language therapist. So we're just going to talk about CURB-65 scores. So patients who have community-acquired pneumonia, we give them a CURB-65 score so we can work out what their mortality risk is and treat them appropriately. So if the CURB-65 score is 0, then the patient has a less than 1% risk of death. If their score is 1 or 2, then somewhere between 1 and 10% chance of dying, and we usually put them on something like dual oral antibiotics. And if the score is above 3, then the risk of dying is more than 10%. We put them on IV antibiotics and oral atypical cover. We usually send off urine and blood samples to look for atypical organisms like Legionella, perhaps Mycoplasma. And then when we think about discharging patients, it's important to make sure that in the past 24 hours, they haven't spiked temperature. The respiratory rate hasn't been above sort of 24 or tachycardic above 100. Their blood pressure has been stable and they haven't been confused. If a patient has underlying COPD, then it's important to give them 5 days of prednisolone, just like you would if they had an infective exacerbation of COPD. Well, thank you for listening. Please do give us some feedback by clicking on the link below to the survey, and we hope to see you next time.